Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be covering pediatrics, but to be more specific, we're going to be covering urinary tract infections. So before we even get started, you know what I'm going to ask you guys, if you haven't done so already. I know the video just started, but you're going to love it, and I don't want you to forget. Please like and subscribe. Like this video, subscribe to the channel if you haven't done so already. Don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. All right, guys, so let's get started. Before we get over here where it says UTI, I wrote something on the side, a reminder. I'm sure this is somewhere in the book, but this is so important. If you guys are currently taking peds, you're learning about UTI right now, whether it's for peds or adults, this is very important to know. One of the biggest teachings you are going to teach, you're going to teach to wipe from front to back. Why? Remember, that meatus is very close to the anal area. We'll get into that, but I don't know why I wrote it on the side. I know it's in the book, but that's something to keep in mind because it's always a test question. Okay, so urinary tract infection. So obviously, guys, that's an infection of the urinary tract. Who's at risk? Look at this. Whites, Caucasians, females, and uncircumcised boys. They have the highest rates, especially girls have a twofold to fourfold higher prevalence than do circumcised boys. And, part of the reason for that is that those tubes are much shorter than the boys. So the pathogens have a lot less distance to travel. Now let's look at the classification. You guys do need to know these definitions. Bacteriuria, just break the words down. Bacteria. Urea in the urine, so it's bacteria in the urine. Pyuria, this is the presence of WBCs in the urine. WBCs should not be found in the urine. Asymptomatic bacteriuria, so the patient's got bacteria in the urine, but there are no signs and symptoms of infection, such as pain, dysuria, frequency, all right? They do have bacteria in the urine, but they're not symptomatic. Make this a little bit bigger for you guys. Okay. Symptomatic bacteriuria. This, you do see the signs of UTI, the dysuria, the pain, the fever. You may see blood in your urea. That's what's known as hematuria, right? RBCs should not be in the urine. So if it's symptomatic, that means the patient's displaying signs and symptoms of the UTI. If it's asymptomatic, that means they're not displaying any of those signs and symptoms of UTI. A recurrent UTI, that's when the patient keeps having that bacteria in the urine, or they're symptomatic over and over again. Frequent UTI, having more than 3 UTIs within a 6-month period. Persistent UTI. Remember, guys, I taught you that word persistent. Whenever you're studying and you see that word persistent, that means that despite evidence-based practice, evidence-based measures, things that you have been taught to do, and if you do it, you should expect XYZ result. Despite performing those nursing interventions or those medical interventions, you're not getting the results that you're supposed to get. That's what it means when you're studying and you see that word persistent. So persistent UTI, that means the patient had UTI. We did what we were supposed to do, which is what, give them the antibiotics, all the things we were supposed to do, but they're still having the UTI, okay? Febrile UTI, that's UTI accompanied by fever. Where am I? By the way, something you guys need to know about the febrile UTI, if the patient has a UTI and they also have a fever, that is a sign to you that this urinary tract infection has ascended, okay? And it's most likely what we're dealing with is pyelonephritis. Cystitis, that's inflammation of the bladder, and usually that inflammation is due to what? Infection, pathogens, bacteria. Urethritis, inflammation of the urethra. Pyelonephritis. Now, I just mentioned this. If the patient, they have a UTI, but they have a systemic or generalized symptom such as fever, you should be thinking they most likely have pyelonephritis. This is inflammation of the upper urinary tract and kidneys. And that's why when I mentioned pyelonephritis, I said those bacteria, those pathogens ascended, because the bladder is lower than the kidneys. So the pathogens have to creep up, right, to get to the kidneys. And urosepsis, febrile UTI. So patient has a UTI, they have a fever, coexisting with systemic signs of bacterial illness. Blood cultures will show, the pathogens present. So what does that tell us? We'll also see that bacteria in the blood, okay, because we're getting it from the culture. So now let's take a look at etiology. Oh, by the way, guys, the two definitions I put a star next to, those are the ones that tend to show up more often for testing purposes, but you definitely do have to know all of these definitions, because those definitions may be part of a test question that you can get. All right, etiology. E. coli. By the way, where do we find E. coli in the stool, right? E. coli remains the most common pathogen overall, but the prevalence is higher in females than males. And again, remember, the pathogens have a shorter distance to travel for the females than they do with the males. Let's look at some radiologic and other tests that are important to know. Urine culture and sensitivity. What's important to know that? Send specimen to the laboratory immediately after collection. Let me tell you something. The urine starts to break down, so you want to make sure you send it immediately after you collect that urine to get tested. Next, voiding cystourethography. Oh, I pronounced it. I'm proud of me. All right. What do we need to know about that? You're going to prepare the child for catheterization. Should not be done at time of active UTI. If the patient has an active infection going, we're not going to do it yet. We're going to wait. And let me explain this to you. And this is across the board in nursing, guys. Whenever you do something invasive, whenever you're introducing a piece of equipment, anything into the patient's body, there's a high chance, a high probability of you introducing infection, of you introducing pathogens into that patient's body. So would it make sense for us to do something like this when that patient already has an active infection, they already have an active UTI? Absolutely not. Next, MRI. What do we need to know about the MRI? That patient is going to have to stay still. Okay, so MRI often requires sedation in infants and children, because you think they're going to stay still for you. Don't mind my nails, guys. I gotta go get it done. You think they're going to stay still for you? Absolutely not. But it's very important for that MRI to be successful. The child will have to stay still. Magnetic devices or implants may be unsafe for MRI, including cochlear implants and permanent pacemakers. You can't have anything metallic such as those for the MRI. And lastly is the CT scan. What's important to know about the CT scan? Non-contrast scan is non-invasive. Contrast-enhanced CT scan preparation may require the child to be NPO for a few hours. So if they're using contrast media, you should expect that child to be nothing by mouth for a few hours. Next, cystoscopy. The child's going to be NPO. Liquids until 4 to 6 hours before the procedure, and then nothing. And the cystoscopy is done under anesthesia in children. Renal biopsy. That's removal of the kidney. I'm lying. Nephrectomy is removal of the kidney. Renal biopsy is removal of a tissue of the kidney for testing purposes. So a part of that kidney will be removed. Some of the tissue will be removed, and it's going to be examined under a microscope. Just joking, guys. All right, so you're going to take the patient's vital signs. You're going to apply pressure to the area. This is very important because this is a very bloody organ, right? So we're going to make sure we apply pressure to the area. Patient's going to be on bed rest for 24 hours. You're going to observe for abdominal pain, tenderness, and you're going to monitor their input and output. Remember, the kidneys are usually our first indicators whenever something's really wrong with the patient, such as them bleeding out. Right. So if there's internal hemorrhage happening, one of the first things we're going to see the urine output decrease. We're going to see the BUN and creatinine start to increase because the kidneys are in trouble, right? We'll see the heart rate increase. We'll see the blood pressure go down. So we really have to pay attention to that urine input and especially output to make sure the kidneys aren't affected. Anatomic and physical factors. The short urethra, which measures approximately 2 centimeters in young girls and 4 centimeters in women, provides a ready pathway for the invasion of organisms. The urethra is very short. So if the child was wiping back to front, or maybe, you know, the younger children, they're just, you know, being potty trained, they're learning how to wipe themselves and clean themselves. There may be fecal matter on the underwear. That underwear is rubbing up against the meatus. It's very easy for those pathogens to climb up the urethra into the bladder and cause an infection. The presence or absence of foreskin has been shown to be a significant factor, with prevalence of UTI in infant males younger than 3 months old being 2.4% in circumcised and 20.1% in uncircumcised males. The presence of a foreskin is associated with preputial colonization of uropathic bacteria that can ascend the urethra easily. And down here on the side, what did I write? I wrote foreskins. Okay, so I wrote the explanation of why. I don't like how the book explained why. Well, they really didn't explain why, but I'm going to explain why. So at that young of an age, that foreskin does not retract fully. Matter of fact, it doesn't fully retract until a little bit after the toddler years. So it's very easy for pathogens to kind of just grow and fester. Okay, and so that's a big reason why we see children who are not circumcised have a higher prevalence of UTI than children who are circumcised. Nursing alert. Current evidence indicates that the health benefits of circumcision outweigh the risk and that the benefits of the procedure justify access for families who choose it, but are not sufficient to recommend routine circumcision for all male newborns. So, you know, studies haven't shown that every single male newborn needs to be circumcised, but it has shown that the benefits definitely outweigh the risks. And you can see that here if you just look at the numbers. The single most important factor influencing the occurrence of UTIs is urinary stasis. Let's stop right there. Give me a second. I got to drink my coffee. It's 7:30 in the morning right now, guys, and I'm about to go teach a 9 a.m. class. So I'm getting this video in before I go teach that class. All right, so let's talk about urinary stasis. Let's talk about stasis of any fluids. Whenever there is fluid that is not moving in the body, bacteria is going to grow. It is a perfect medium, a perfect environment for bacteria to grow and flourish. So if urine's not moving, guess what's going to start growing? Bacteria. Look at this. The single most important host factor that influences occurrence of UTI is that urine not flowing, that urine just sitting there. Under normal conditions, the act of completely and repeatedly emptying the bladder flushes away any uropathogens before they have the opportunity to multiply and invade surrounding tissues. However, urine that remains in the bladder after voiding allows pathogens to rapidly establish in bladder tissue and cause symptoms. Incomplete bladder emptying stasis may result from reflux. Now let's talk about altered urine bladder chemistry. Increased fluid intake promotes flushing of the normal bladder and lowers the concentration of organisms in the infected bladder, thereby decreasing the risk of UTI. So it's very important to have patients drink lots of fluids. Why? We want to flush out that bladder. Children with UTI should be encouraged to have adequate water intake, about 8 ounces of an 8-ounce cup of water per year of age until 8 years old. Let's say that again. 8-ounce cup of water per age. So if they're 4 years old, 4 8-ounce cups of water. You understand? All right, until they're 8, to aid in the prevention of further infections. Diuresis also seems to enhance the antibacterial properties of the renal medulla. So it's important to flush those kidneys out. Normally, the urine is slightly acidic with a median pH of 6. We want to keep the bladder in an acidic environment because the bacteria don't tend to grow and flourish as well in a more acidic environment. Cranberry products appears to decrease the adherence of certain bacteria to the bladder wall. So let's talk about this, because you know when patients have a UTI, they're taught, drink cranberry juice. We're not 100% sure, but what we think is happening, that acidity of the cranberry, that's what keeps the bacteria from sticking to the inner lining of the bladder. So when they have that, drink the cranberry juice, the environment is more acidic, the bacteria can't stick to the inner lining of the bladder. So when the patient urinates, that bacteria is flushed out instead of sticking to that bladder and multiplying, okay? Recent review of literature showed that cranberry products did not significantly reduce the occurrence of symptomatic UTI overall or in any subgroups. Because the benefit is small, cranberry juice isn't currently recommended for prevention of UTIs. Diagnostic evaluation. Diagnosis of UTI is confirmed by detection of bacteria in what? Urine culture. That's your key. Urine culture. So they take a culture of the urine to see exactly what bacteria is growing, to see exactly what type of antibiotic that bacteria will be sensitive to, right? Unless the specimen is a first morning sample, a recent high fluid intake might indicate a falsely low organism count. Therefore, the child should not be, let's go to the next page. They should not be encouraged to drink large volumes of water in attempts to obtain a specimen quickly. Why? Because them drinking all of that fluid before we gather the urine for collection might give us a falsely low count. A child who exhibits the following should be evaluated for UTI. Incontinence in a toilet-trained child. So this child's been potty trained, but now all of a sudden they're urinating on themselves. They can't hold it. Frequency or urgency of voiding, painful voiding, dysuria, gross hematuria. We are not supposed to see blood in the urine. The most accurate tests of bacterial content are suprapubic aspiration for children younger than 2 years old and properly performed bladder catheterization as long as the first few milliliters are excluded from collection. The specimen has to be fresh, less than an hour of storage of room temperature, less than 4 hours if refrigerated, to ensure sensitivity and specificity. I hate this. I hate this so much. You guys see this word? That's what they're talking about. Of the urinalysis to prevent growth of the organisms. Urine dipsticks indicate the presence of leukocyte esterates and nitrites. We're not supposed to see neither one of those in the urine, by the way, and are quick and expensive. So a urine dipstick is a quick test we can do to see if the patient most likely has a UTI. Because remember, guys, when it comes to the urine cultures, are we getting results right away? No, because that culture has to grow, right? Okay, so if we need something quick, we can do a dipstick. Leukocyte esterase is a surrogate marker for pyuria, and nitrite is converted from the dietary nitrates in the presence of most gram-negative enteric bacteria in the urine. All of that to say is we should not be seeing those nitrites or the leukocyte esterates in the urine. Use of a microscopic urinalysis for pyuria should be used for confirmation and diagnosis. At the end of the day, the definite test, guys, is going to be from that culture. They can also do, ultrasound, voiding cystourethrogram, DMSA, but usually, guys, the dipstick, that's the quick method, or the culture. Therapeutic management. Antibiotic therapy should be initiated on the basis of identification of the pathogen. And how do we do that? By the urine culture. That culture tells us exactly what's growing and exactly what that patient's going to be sensitive to. Because guess what? We don't want to give an antibiotic that they're going to be resistant. We want to give something, that they're going to be, sensitive to, okay? The child's history of antibiotic use. Why is the history of the patient's antibiotic use? Why is that important to us? Because let's say the healthcare provider was going to order Cipro. And you ask about their history of antibiotics, and we find out that they're allergic to Cipro, number one. Or number two, they had infection a month and a half ago and they were on Cipro. Do you think we're going to give Cipro to that medication? Do you think we're going to give Cipro to that patient? Absolutely not. So finding out their history of antibiotic use, that's very important, and the location of infection. Several antimicrobial drugs are available for treating UTIs, but all of them can occasionally be ineffective because of resistance of the organism. And again, guys, this is why that urine culture, the culture and sensitivity is very important. We need to know what that patient's resistant to so we know what not to give them and what they're sensitive to. Because if the healthcare provider orders something and you look at that culture and sensitivity report and whatever it was that they ordered, that patient's resistant, are you just going to be a blind robot and give that medication to the patient? Absolutely not. You're going to call the healthcare provider and say, hey, I know you ordered this, but I'm looking at the culture and sensitivity. The patient's resistant. Are you sure you want to give it? Okay. Common anti-infective agents used for UTI include, you need to know this list, penicillins, sulfonamides, and cephalosporins and nitrofurantoin. All right, let's talk about vesicoureteral reflux. Vesicoureteral reflux, that's VUR. This refers to the retrograde flow of urine, look at this, from the bladder into the upper urinary tract. So it's creeping up from the bladder and it's going up the urinary tract up to the kidneys. When the bladder pressure is high enough, refluxing urine can fill the ureter and the renal pelvis. So now you have urine and bacteria that was in the bladder, but now it's crawling back up the ureters to the kidneys. Children with pyelonephritis are often symptomatic with high fevers, vomiting, chills. I want you to notice something. These are systemic symptoms that we're seeing. So when you see a patient with a UTI, but you're seeing those systemic symptoms, such as the fever, those vomiting, chills, you better be thinking of pyelonephritis. In most cases, conservative therapy is sufficient with a high rate of spontaneous resolution of the VUR over time. Prevention of infection has been the goal with use of continuous antibiotic prophylaxis, common practice until resolution or correction of the VUR. Urine cultures are not recommended routinely for children with VUR, but should be obtained, if the patient's symptomatic. And it makes sense because guess what? If we have urine and bacteria that's flowing from the bladder up those ureters to the kidneys, you constantly doing those cultures, that cultures are constantly going to be positive, right? And so we're not going to constantly do those cultures where we're constantly giving that patient antibiotics because we understand what's going on. We know what the problem is. We're trying to fix that underlying problem, which is that reflux. Now, let me be specific because look what the book's saying. if that patient is not symptomatic. Then obviously, guys, if they're symptomatic, we're going to do those cultures so we can give them antibiotics. But if they're not symptomatic, we're not just going to keep doing these urine cultures just to do it. That's what the book is saying. And this, by the way, that goes for adults as well. So quality outcome from the UTI. We want to give them treatment based on the culture and sensitivity. We don't want to give them antibiotics blindly. Renal function is maintained. We want to make sure kidneys not affected, appropriate diagnosis of the renal abnormalities. Nursing care and management. Nurses should instruct parents of those with VUR to observe for signs and symptoms suggestive of UTI. We went over those signs and symptoms. You know, if they're potty trained, but all of a sudden they're urinating on themselves. It hurts when they urinate. They have to urinate all those times. They have to urinate all the time. They're seeing blood in the urine. Those signs and symptoms of infection, okay? A high fever without obvious cause should be a signal to check the urine. When it comes to peds and the patient is having a high fever, but it's not like they're coughing. It's not like they have an upper respiratory infection and we don't know what's causing that high fever. We're always going to check the urine in peds because very often what's causing the fever is a UTI. A careful history regarding voiding habits, stool patterns, feeding tolerance, and episodes of unexplained irritability can help you detect if it's a UTI or not. Nursing alert. Another strategy for obtaining a daily urine protein is to place cotton balls in the diaper at night before bedtime and then squeeze the cotton balls in the morning. This should not be used if you're looking for a urinary tract infection. Again, guys, look what they said. Daily protein. When infection is suspected, collecting an appropriate specimen is essential because remember, our definite diagnosis is going to come from that urine culture. It is a nurse's responsibility to take every precaution to obtain acceptable, clean, voided specimen in a child who's able to void volitionally, taking care to cleanse the meatus and retract the foreskin in uncircumcised male or keep the labia separated in females. And even guys, even when you're cleaning that area for the girls, you're going to clean from front to back, right? One sweep. You're not going to go from back to front to back, then back to front. One sweep front to back. Then you're going to get another cleaning cloth, one sweep front to back. Having a young girl sit backwards on the toilet can facilitate this process. Why? Because remember, you want the labia open. Particularly the ability to obtain the urine midstream, decreasing the risk of contamination. We're getting that urine midstream, guys. Remember that first couple drops of urine, we're not collecting that. We want that urine that's coming from the bladder. Because of the unreliability of a specimen obtained via a urine collection bag, sterile catheterization should be done in infants and young children whose illness warrants immediate antibiotic therapy, as with high fever, vomiting, and lethargy. Frequently, additional tests are performed to detect anatomical defects. Sometimes that child may be having recurrent UTIs because anatomically speaking, there may be a defect, okay? Children are prepared for these tests as appropriate for their age. This includes an explanation of the procedure, the purpose, you know, what the child will be experiencing. For younger children, for children younger than 3 to 4 years old, the procedure can be explained on the doll. This has been seen on NCLEX very often. Make sure you know that. If it's a younger child, you can explain the procedure using a doll or a toy that they have, and you can use the body parts to explain. For the children who are older, a simple drawing of the bladder, urethra, ureters, and the kidneys makes the procedure more understandable. Handling actual equipment when possible can be helpful in decreasing the child's anxiety. Anticipatory instructions on distracting techniques such as deep breathing, storytelling, imagery can help the child relax and be more cooperative during the actual procedure. Because antibacterial drugs are indicated for UTI, the nurse advises the parents on proper administration dosages and to teach them to give the entire amount of medication, even if the child starts to feel better. All right, let's talk about prevention. Prevention is the most important goal in both primary and recurrent infection, and many preventative measures are simple, hygienic habits that should be a routine part of daily care. For example, and you guys need to know this, parents are taught to cleanse the infant's genital areas from what? Front to back. From front to back to avoid contaminating the urethral area with fecal matter. Girls are taught to wipe from front to back after voiding and defecating. Children should void as soon as they feel the urge, and they should not be encouraged to hold their urine for prolonged amounts of time, because you know what happens when urine sits there in the bladder. Sexually active female adolescents are advised to urinate as soon as possible after they have intercourse, and this goes for adult women as well, to flush out any bacteria that's introduced. So as soon as they have intercourse, they should go and urinate. Children who have recurrent UTIs or neurogenic bladder are sometimes maintained on daily low-dose antibiotics. Giving the dose at bedtime in children who stay dry through the night allows the drug to remain in the bladder for longer, so it makes it more effective. The nurse should reinforce the importance of compliance to parents and older children. One more thing I want to go over with you guys. Prevention of urinary tract infection. Factors predisposing to development. Short female urethra. That urethra in the female is much shorter and is closer to the vagina and anus. So pathogens can ascend very quickly. They don't have a long way to go, right? Incomplete emptying and overdistension of the bladder, that urine just sitting in the bladder, creates a medium and environment for bacteria. Concentrated urine, not drinking enough water, and constipation. All of these are predisposing factors for UTI. Now, what are measures to prevent UTI? Again, practice perineal hygiene. Wipe from front to back in females, very important. Avoid tight clothing or diapers. Wear cotton panties rather than nylon. Avoid holding the urine. When you gotta go, go. Flush that bladder. Take time to empty the bladder completely. You don't want any urine still staying in the bladder, because that's caused what? Urine stasis. Avoid constipation. That's another biggie. See, I put a star next to it. And adequate fluid intake. Drink lots of fluid. Guys, that is your UTI for the pediatric patient. Please let me know what you thought about this video in the comment section. And let me know what you'd like to see me cover next or more extensively. Don't forget, on Sundays, 1 o'clock Eastern Standard Time, I have videos that are published every week, every Sunday, 1 p.m., where I cover a variety of questions. If you'd like to see me cover a topic on one of those, go ahead and let me know in the comment section as well. Don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. Thank you so much for watching, and you guys will catch me on the next video.